Well, we're going to go ahead and get started. Greetings and welcome. My name is Brad Monk, and I'm so happy to be with you. We have had satellite symposia before, but never like this. This is a satellite symposium in anticipation, and I have no confidential or secret information. But this is being done in anticipation that you will have a new medication in the clinic imminently, 3 weeks, maybe 4 weeks. And you're going to need to know how to use that medication, and you're going to need to know how to contextualize that medication and how the heck you're supposed to figure that out, right? So hopefully through this satellite symposium. So I'm really excited to be here. This is an independent satellite symposium sponsored by CGen, but they had no input into the development of this content. We used to say that, if you had a commercial interest, now we call it an ineligible company. Even the conflict of interest field is evolving, and all relevant financial relationships are listed and have been mitigated. So that's very important to us. These are the disclosures verbally. They're also found on our website, and these are very important. This is a continuing medical education accredited program through the ACCME, and it will provide 1.25 AMA PRA Category 1 credits. There are no fees to receiving these credits. You just have to read the objectives and disclosures, attend the activity, and then complete the pre and post test evaluation. So I encourage you to do that. So I'm here with some international experts and friends. And I already introduced myself, Brad Monk from Phoenix, Arizona here. I'm actually here in Tempe in clinic, and I work with the GOG, and I work with US Oncology, and I work with you. I'm also joined by Brian Slomovitz. Brian, go ahead, introduce yourself. Take yourself on mute and say hi.
Hey guys, thanks, Brad. Brian Slomovitz. I'm a gynecologic oncologist, professor of OBGYN at Florida International University, and I'm the director here at Mount Sinai Medical Center in Miami Beach. And also, I love being involved with the GOG. I'm on the board of directors of GOG, and I work with their cervical trials, and I lead their uterine cancer trials, but I'm working on one of their cervical trials as well. So Brad, thanks for having me. And I love the education part of this. So thanks for having me.
It's going to be a lot of fun, and I appreciate your enthusiasm and for all the hard work you put in to making your slides. I've seen them. And you're going to talk to us about the current therapeutic landscape in cervical cancer. I'm also joined by Dr. Leslie Randall, who's going to talk about sort of what's next. And Leslie, welcome. Say hello and introduce yourself.
Hi, thanks for having me, Brad. I'm really excited to be here, and really excited to have new treatments for cervical cancer. I'm going to talk tonight about how this is moving really fast. So for those of you that joined tonight, I hope that you'll get a lot out of this tonight. I know you've got a lot of other things going. I'm the division director of GYN Oncology at VCU Massey Cancer Center in Richmond, Virginia. And I also run the clinical cervical cancer portfolio for GOG partners under the GOG Foundation. Great to be here. Thank you.
Yeah, I'm so happy to have you. And thank you for your hard work, both you in managing the cervical cancer portfolio and Brian for the endometrial portfolio, but there's a lot of cross-pollination, as I say. So I think, and what I'm hearing from the FDA, I just read it on their website, that the first antibody drug conjugate will be tisotumab vedotin in gynecologic cancer. I think so. And so if that happens, I need us to be ready, and that's what we're here to do. I had the pleasure to enroll in the phase 2 study. I think our site was the leading enroller to the phase 2 study. And now just at the IGCS, I presented a novel combination clinical trial that we all ran. So I have some experience here, and I want to share that with you. And hopefully we can not only talk about the clinical opportunity, but the toxicity at the end of the presentation. So we have some objectives here. One is to increase key clinical trial data for newer therapies. And then also understanding investigational agents and regimens, and then greater competence in how to treat these women with existing medicines and medicines that ideally will be available soon, most importantly, it's all about the patient experience and how to counsel them to enhance that experience, helping them live longer, but also living better. So I'm going to turn it over. I want polling questions. I love these because then we get to know more about you. So let's go ahead and what region of the world are you from? You'll have the opportunity to vote here on your screen. So go ahead and vote, and go ahead. And I'm going to vote too. Arizona is in the Southwest, not the West. All right, you pull up the answers, and we could even have a 15-second music if you want. So East Coast, that's great. We'll go to the next question. How many years have you been in practice? This is always painful the older you get. So go ahead and vote now. Laugh it up, Leslie.
No comment.
Okay, well, we have some seasoned veterans, as I say. NFL football starts. We're holding it at this time so you guys can watch the Dallas Cowboys beat the defending champion Tampa Bay Tom Brady.
Do you have any inside information on that score, or is that based on your opinion?
Cowboys by 7. So what's your specialty? Go ahead and vote now. So we have some industry people. That's good. Quite a few, actually. Hopefully we can educate you, because if you are working with these agents, and I'm sure almost all of you are, it'll be important to understand how they're relevant as you talk to people about them. And that's exciting. Does your site participate in GOG trials? So go ahead. Well, that's good. We have a seasoned group. So hopefully some of you have used some of these novel agents in the clinical trial setting. And now I developed these because I really want to know, and I want you to give this some thought. So I'm going to read this before we turn on the music. So I'm anticipating that tisotumab vedotin will get FDA approved soon. So after checkpoint inhibitor, so it's not versus checkpoint. Once the patient has exhausted the checkpoint inhibitor opportunity, and maybe you don't know the data for TV, and if you don't, we're going to talk to you about it. What would be your go-to option in this sort of second line recurrent cancer after failing, let's just say either after or third line, maybe you can give, checkpoint inhibitor second line, but after exhausting checkpoint inhibitor, what's your go-to medication or going to be if TV is approved? Yeah, that's interesting. Okay, well, I hope that can be supported by the data.
I was going to say, Brett, is our night over? Can we go home?
I say go home.
I'm kidding.
Watch the game.
Well, but it has to be
about.
given. It's one thing to say I want to do it. The question is, do you know how to do it? Right? Do you know what the dose is? Do you know what the adverse reactions are and how to mitigate it? So we'll talk about that. So I also think that balstilimab is going to get approved. It has a PDUFA date of December 16th, and it'll compete for pembrolizumab. And I don't know whether it'll be the PD-L1 positive, but it might be. And I think you've all seen the Empower data, and I know we're going to review it here today. But I think it's likely that when you say, checkpoint inhibitor, you're going to have 3 options: cemiplimab, balstilimab, and pembrolizumab. We're going to hear about the data, but I kind of want to know where you are today. If all 3 are approved, which one are you going to do?
Hey, Brett, I just want to interrupt you for a second. And I love our friendship, and we go back and forth to keep each other in check. Can you describe to everyone what a PDUFA date is? Because
thank you.
A wide range of people. I just wanted to make sure everyone knows.
Yeah, so as you know, the FDA is a government agency, and government agencies are governed by law. And the law is called the Prescriber Drug User Fee Act. And within that law, it sets the boundaries and the rules for getting a drug FDA approved. And it actually says how much money it costs per prescriber drug user fee. And so we abbreviate that into PDUFA, and that is the action date. So when the FDA accepts an application, they say, okay, we'll take it. And there are many submissions that are not even accepted and you don't hear about it. But once they say, okay, it's accepted, they give you some information. One is the timing. And if it's a new chemical entity, it's 8 months. If it's a secondary approval, it's 10 months. And if it's very exciting and it's a secondary, it's 6 months. So these are generally 8 months because these are new entities. Cemiplimab will be a secondary drug approval, so that'll be a 6-month, assuming it's a priority review. The slower process is a 10-month, and then they tell you if they're going to have an independent committee called an Oncology Drug Advisory Committee, and that's all laid out in the law. And so a PDUFA date is the action date. It doesn't mean it's going to be on that date, and they can extend it, but it gives us a sense so we can sit together like we are here today and anticipate it so that we can be prepared. Good question. So let's go ahead and see the answer to this question. All right. Interesting. So, and we can draw some analogies between our PARP inhibitors, right? So olaparib was the first PARP inhibitor. It's where our familiarity is. And I think probably olaparib is the most, I don't know, probably one of the more common PARP inhibitors. And I think pembrolizumab being familiar, also being every 6 weeks, we'll have some opportunities. So I like that, and we'll see what happens. So I'm gonna turn over to you, Brian. Good seeing you. I'm gonna turn my camera off while you talk, and Leslie, you can turn your camera off, and let's hear about the current landscape, Brian. Thank you.
Thank you very much. And again, thanks for having me. We're a little bit behind on time, but I promise I'll make it up a little bit to keep us going. Here's my disclosures. And again, the purpose of my talk is to really talk about the things that are approved, and then Leslie's going to take us into the future direction. Cervical cancer is estimated 14,000 new cases of invasive cervical cancer in the US in 2020. It is a disease that is persistent, and we need to do better with treating it. It represents a better treatment options do represent a tremendous unmet need. The death rate in 2016 was 2.2 per 100,000 and was less than half that in 1975. So from 2007 to 2016, the death rate decreased about 1% per year in women greater than 50 of age and older, but was stable in those women less than 50. And as we know, given the fact that HPV is really a driver for this disease, it is a disease that we do see in younger women. Here's the staging system, and there's actually an update in the staging system in 2018. There's a lot of information on this slide. I'm not going to spend a lot of time on it, but in summary, stage 1 disease is limited to the cervix. When it's stage 1B1, we expanded this out in the newer staging system. Originally 1B1 and 1B2 was less than 4 centimeters and greater than 4 centimeters. Now we've sort of increased that to 1B3, which is those tumors greater than 4 centimeters. 1B1 is the greater than 5 millimeters in depth and less than 2 centimeters in dimension, and 1B2 are visible lesions less than 4 centimeters. For me, with all else being negative, I use this as a guideline to see which patients I'll operate on, 4 centimeters or less, versus which ones I'll give primary radiotherapy. The stage 2s really haven't changed much. Stage 3 does include now lymph nodes. In the past, lymph node involvement was not part of the staging system, but now if there's periortic involvement, there's stage 3C2, pelvic node involvement, stage 3C1, and stage 4A remain the same. Here's a summary of treatment that I really stand by. Cervical dysplasia or stage 0 disease. Those patients are often treated with an excisional procedure, cone biopsy, occasionally cryotherapy, laser, or LEEP treatment. Early stage disease, that's stage 1A1, 1A2, up to 1B2. Oftentimes these patients get surgery followed by adjuvant treatment depending on the risk factors. Locally advanced disease, which I'll expand on a little bit. These patients are getting chemosensitizing radiation. Widely metastatic disease or stage 4B at the time of treatment. It doesn't make sense to give a regional treatment, so we give systemic treatment, and I'll get into that as well. In the first line is platinum-based chemotherapy with bevacizumab is the current treatment. Second line, pembrolizumab for those patients PD-L1 positive, or single agent chemotherapy. Radiation is very important for those patients with locally advanced treatment. Traditionally, it was AP-PA fields that moved on to 3D conformational, and now we're using more and more of IMRT. Radiation oncologists are a big part of our treatment team, and giving the best treatment in conjunction with them is very, very important. As I mentioned earlier, we are giving what I call baby doses or chemosensitizing doses of cisplatin, 40 milligrams per meter squared, maximum of 70 milligrams in the treatment of these patients. Treatment timing is very important. And this is difficult because a lot of these patients One of the risk factors for cervical cancer is low socioeconomic status, and sometimes it is difficult to get these patients into our quote unquote symptoms. However, we do know with getting pelvic control less than 55 days does portend a overall approval in both pelvic control and survival, as you could see from the Kaplan-Meier curves demonstrated here. Greater than 55 days, which unfortunately still does happen for some of our patients, given limitations in our systems and some of the financial toxicity associated with treatment, but that's associated with a worse prognosis. Brachytherapy is the most important part of the radiation treatment plan for these patients. This is something that really Dr. Monk has hammered home to me, and I really making a point to make sure we give good brachytherapy. And an alternative that some people think about is just to increase the dose of external beam, particularly the cervical area, but this is not good enough. These patients with cervical cancer do need good brachytherapy, even if it means taking to the operating room for Schmidt sleeve placement or interstitial needles in order to get the best control. Brachytherapy, as you can see on the right, does yield a better cause-specific survival in these patients. And unfortunately, we do see an underutilization. There's some SEER data showing brachytherapy utilization decreased from 1988 to 8.83% down to 58% in 2009. I mentioned good brachytherapy yields a better survival. A study of patients with cervical cancer in California showed a 45% brachytherapy utilization during the study period, with decrease in survival outcome associated with that. NCCN guidelines are listed here, and these are readily available. Talking about the best treatment options, surgical staging with periaortic node involvement can help to define the treatment fields for radiotherapy. If it's done by radiologic imaging alone, it's probably not as good as surgical staging, but it also too can determine which patients need extended field. Most recently, this is a trial that Katie Moore represented the GOG, a large international trial called the Outback trial. This was presented in this year's ASCO meeting. It evaluated in patients with locally advanced disease, it evaluated the chemosensitizing radiation followed by carboplatin paclitaxel as a way of better controlling these patients with locally advanced disease. Unfortunately, the addition of chemotherapy did not improve significant PFS or OS. And I say unfortunately because we need to do better for these patients. But we also learned by adding chemotherapy can increase toxicity without benefit. So we learned from this trial not to include subsequent chemotherapy after treatment of locally advanced cervical cancer with chemosensitizing radiation. Here's the patterns of disease recurrence. Site of disease progression were not significantly different between the treatment arms. And as far as the sensitivity analysis, there was an absolute difference of 3% for overall survival, which was not greater than expected by chance alone, rendering this study to be negative and not incorporating it into the treatment. Lessons we learned from this Outback trial: there was a high dropout rate with switch maintenance strategy. With a long post-progression survival, the preferred endpoint for these type of trials is progression-free survival. With almost 100% crossover, meaning those patients that didn't receive chemotherapy in the treatment arm of the study, they received some sort of platinum-based therapy afterwards. So overall survival is not the preferred endpoint. Newer agents need to be looked at, and Leslie is going to dive into that a little bit more. What about those patients with metastatic disease, stage 4B patients? It does represent an unmet clinical need. To go through where we are to where we got to today, Brad and Kirsch Chouari are really two leaders in this field, and it's really a pleasure for me to learn a lot from them. GOG 204 looked at a four-arm regimen. 434 patients were randomized to, all of them received cisplatin with either paclitaxel, vinyl-relbine, gemcitabine, or topotecan. The response rates are listed here: 29% for the paclitaxel-containing arm, going down 26%, 22, and 23% with comparable toxicity. This study really demonstrated that the most standard arm that we're using is platinum-based chemotherapy with paclitaxel, and this yield turned into the standard treatment arm in the control arm in subsequent trials. JCOG then did a study of cisplatin versus carboplatin. As we know, a lot of these patients have a blockage of their kidneys, and we want to try to limit renal toxicity. This study found that giving carboplatin, which has less renal toxicity, is just as good as those patients who receive cisplatin, allowing for incorporating that into our treatment plan, particularly in those patients that do receive cisplatin chemosensitivity. We do want to sort of change things up a little bit. Giving them carboplatin is a good option, and I use that a lot in my practice. The follow-up study for this was looking at the paclitaxel cisplatin or paclitaxel topotecan plus minus bevacizumab, which is GOG 240, led by Kirsch Tiwari, published in the New England Journal of Medicine. And bottom line is the addition of bevacizumab was incorporated into the standard treatment of these patients as it improved both median overall survival and progression-free survival for those patients, regardless of the chemotherapy backbone. Toxicity is demonstrated here. With bevacizumab, we worried about fistula rates. Even though it's higher in the bevacizumab arm, it's really not as high as what's reported in some of the other disease sites. We see higher hypertension with bevacizumab. Proteinuria was comparable, 32 and 28%. And the other numbers are listed here. That made the 240 regimen the standard of care of cisplatin, paclitaxel, and bevacizumab, or based on the, we do trade out cisplatin with carboplatin. Cervical cancer, however, is a disease that is amenable to immunotherapy. Unlike ovarian cancer, which in 3 randomized trials demonstrated no benefit of immunotherapy in cervical cancer and endometrial cancer, we do see that immunotherapy does add to the treatment options. We can see here, based on a lot of it's based on tumor mutational burden, the higher TMB as seen in cervical cancer does make it more amenable to immunotherapy. Keynote 158 is a study of looking at pembrolizumab in the second-line setting. Treat for 2 years or until progression, survival follow-up. The primary endpoint was overall response rate. And here we find that the overall response rate was 14%. Remember, cervical cancer doesn't have a lot of treatment options in the second-line setting. This 14% led to the FDA approval for the treatment of PD-L1 positive, it's biomarker-driven therapy, or really what we call as a CPS score, in cervical cancer. And most recently, we give Q6-week dosing, which is the benefit of our patients. Led to the FDA approval on June 12th, 2018. And really what we do is, it's all about FDA approval. The more drugs that get FDA approved, the more treatments we have for our patients. And that's why Dr. Monk was really emphasizing that with the 2 PDUFA dates in his introduction. So a summary at this point, first-line therapy, chemotherapy plus bevacizumab. Second-line therapy is we're starting to incorporate immunotherapy in addition to some of the second-line chemotherapies. Last but not least, for my part of the talk, is most recently presented by Kirsch Tiwari, again, one of the leaders in this field, looking at, in the second line, cemiplimab, which is a checkpoint inhibitor, versus chemotherapy for patients with recurrent metastatic disease. Here's the study schema. And again, I'm trying my best to catch up on some of the time here. Primary endpoint was overall survival. Bottom line, in the squamous cell population, there was a benefit, hazard ratio of 0.3, statistically significant, 11 versus 8.8 months with chemotherapy. And what we didn't see with the Pembro wasn't really evaluated as evaluating adenocarcinomas. We also saw a significant difference, 13.3 versus 7 months. Yet to be approved, however, this data was presented, and in the overall population, cemiplimab beat out chemotherapy, 12 months versus 8.5 months. Again, a little difference, but it was clinically significant and better for our patients. Progression-free survival didn't in the squamous cell population did benefit. I just want to get through here. First time this study also looked at quality of life, and what we found is that there was a significant benefit of cemiplimab when compared to chemotherapy, statistically significant in the overall population. It's not only efficacy in the second line setting that we're looking for, but it's quality of life as well. I got through what I wanted to. I'm really excited to hear Leslie's talk on the future. The future is bright, and here's just a picture of, I see this out my window at work, so come down and visit us in Miami Beach anytime. Brad, thanks for your time, and Leslie, I look forward to your talk.
Yeah, that was good, very succinct, and I'm on my way. So Leslie, go ahead and take it away for our next section on what clinical trials are ongoing.
Awesome, thank you. Okay, great talk, Brian. I'm gonna set us up. I want to use my talk to kind of give you everyone an idea of what else is coming, what needs there are going to be, and how fast it's all happening. So let's take it away here. So you heard from Brian, this is like the current landscape of treatment. And my point with this slide is just to show you where the opportunities exist, and they mostly exist for our locally advanced patients and then our metastatic and recurrent patients. And the second point of this slide is to remind you that we have not changed the standard of care for locally advanced cervix cancer since that NCI clinical alert in 1999 that I was like a medical student when that came out. And, you know, I'm getting up there in age. And then 2013, 2014 was the GOG 240, and then pembrolizumab came online in 2018, but really, again, only for that restricted PD-L1 population under an accelerated FDA approval. We don't even have full approval of that yet. So this is, you know, where we are. And so Brian showed you that this is really still a high unmet medical need where accelerated approval opportunities still exist. This is, again, just rehashing the outcomes of the single agent PD-L1 agents, pembrolizumab, cemiplimab, balstilimab, and a fourth one that was presented just this past week at IGCS called socazolimab, which interestingly, you can see, most of you know the PD-L1 positive response rates, the PD-L1 negative response rates, and interesting, you know, socazolimab sort of stands out here because it's a bispecific antibody and a portion of it is an antibody drug conjugate. And so that part of the drug has not really been publicly disclosed what exactly that is, but it's interesting because, you know, we're really here to talk about ADCs tonight. So the single agent checkpoints have already moved into the front line, and they were so exciting. The rationale that Brian showed you was so good that we, in a way, sort of threw the spaghetti on the wall and really started to aggressively investigate this in the phase 3 setting in the front line. So we have 3 trials in the GOG 240 space, the GOG 240 backbone with or without the PD-L1 or the PD-1 or PD-L1 in the case of atezolizumab agent of choice for the trial. Keynote 826 will be presented at ESMO next Saturday. So that's coming. And this was Keynote 826 and the Fermata trial in Europe are plus or minus bevacizumab, and BCC differs in that it mandated bevacizumab. And so you can see the primary endpoints here and really starting to incorporate progression-free survival into our frontline trials because patients are going to get the investigational therapy and potentially multiple lines of therapy, and that starts to make the overall survival endpoint not interpretable. And that happened in ovarian cancer, which you guys probably remember when we switched from OS to PFS as our preferred endpoint. And to me, what that means is there are active therapies in the second line and the third line, and that is awesome for our patients. We have not been there yet with cervical cancer, but it's, you know, we're getting there and we're almost there. We just got to get these medicines to the clinic. This is the first interim review of the Keynote 826, a press release that came out June 22nd. Many of you are probably very aware that this trial met its primary endpoint, showing a benefit of pembrolizumab, regardless of PD-L1 status, regardless of whether patients had received bevacizumab or not. Now, I don't know what that means. You know, your question is, oh, I don't have to give bevacizumab anymore. I don't think that is the exact response that we should have. We need to see what this ESMO data shows with regard to bevacizumab. We know that Bev had an important overall survival advantage in 240, and it would be hard for me to think that somehow pembrolizumab negated that, but, you know, we'll see with the data and BEAT-CC coming online. Here's the design of BEAT-CC where we mandated bevacizumab. I think we might need both of these trials to be able to interpret whether, you know, what the advantage of giving Bev in the front line if we were, you know, start giving pembrolizumab in the front line. So my guess is that we're going to continue to give both, but we do need more information here, and that's coming online soon. And the BEAT-CC trial was also run through GOG Foundation partners and in collaboration with GEICO and NGOT. and that completed enrollment, but the results will probably be quite some time from now. For locally advanced disease, and the time that we were starting these frontline trials, we saw the Pacific trial in non-small cell lung cancer in an unresectable stage, which is kind of similar to cervical cancer and its disease distribution, not necessarily in its biology, with cervical cancer having a better biology for immunotherapy, at least biologic rationale. The Pacific trial showing a very significant improvement in overall survival for those patients who got durvalumab maintenance after chemo-RT. So that we had already started thinking about that. Jyoti Mayadev had already started looking at that in the NRG GOG with her 9929 protocol that combined a CTLA-4 agent with chemo-RT. And there's no control group here, so it's hard to interpret progression-free and overall survival. But if you look at this, and Brian just showed you the historical controls for Outback, were an OS typically in the 60% range. For this was a periordic node positive high-risk population, so a very significant improvement against the historical control. But this is a small study and needs further investigation in a larger trial, but this is happening with our current locally advanced phase 3 trials. And I'm going to go through this kind of quickly. Just to shout out to Dr. Duska, who has done an early phase trial of pembrolizumab with chemo-RT, both sequentially giving the chemo-RT and then starting the pembrolizumab, or concurrent chemo-RT with pembrolizumab to follow. And Cala and our own GOG 3047 Keynote A18 collaboration with NGOT. These are both locally advanced cervical cancer trials. They both start immunotherapy during the chemo-RT and continue it afterwards as maintenance for up to 24 months. Cala has completed enrollment, and enrollment in GOG 3047 is ongoing. And if you have this trial, or if you know someone close to you that has this trial, we're very actively and aggressively trying to recruit to this study. And both of these trials I've mentioned are patients that are more high risk. So they either have very advanced local disease, the old school 3B staging, or they have positive nodes. So the new 3C, or any tumor sites with positive nodes are eligible for this study. And this is basically the schema. So chemo radiation with or without pembrolizumab, both during the treatment and afterwards as maintenance. So here's Leslie Randall's crystal ball, and it's not just me. I mean, this is really kind of where the data is taking us, is that these PD-1 inhibitors are going to move into the frontline therapy. So these are going to be probably used at the locally advanced stage. Hopefully we'll cure people here. We don't know that yet. That remains to be seen, obviously. But metastatic disease immunotherapy will be incorporated into that front line. And then for second line patients who've come in, with metastatic, and even immunotherapy is probably still not going to cure them. What are going to be the options now that PD-1 is no longer an option because they've already had it? So we really need non-IO options, and we've still got TILs under tumor infiltrating lymphocytes under investigation here, but really TILs have mostly been looked at pre-immunotherapy, and there's a new protocol to look at them after immunotherapy. Same for recurrent disease. So if patients have recurrent disease, the question now, it used to be, have they been radiated or not? Now the question will be, have they had prior checkpoint or not? And whether they've had prior checkpoint is going to dictate what their downstream treatment is. And so, there's so many parallels. Brad already mentioned a parallel to PARP. Here's another parallel to PARP. When we moved PARP very quickly up to the front line, and now we may be getting ready to find out what it looks like to give PARP after PARP. But now we're in a situation where we need to find out what it looks like to give checkpoint after checkpoint. So I made those points, so I'll move on. This is the TIL trial, LN145, as it actually has a new name, which it's hard for me to pronounce, like lifileucel. And these are the preliminary outcomes with TIL therapy. And you all probably remember when Christian Heinrichs reported his NIH study of 2 complete responses. One, a patient who had been very heavily pretreated, which was kind of like a miracle treatment. That was actually the first immune therapy that appeared to work for cervical cancer. But here you see a 44% response rate with 11% complete responses, here a near complete response. So these are really excellent results for these patients. But again, this is in the context of no prior checkpoint therapy. And as we all know, that's can be a difficult treatment to give. And so it's not going to be for everyone. Here's what's coming following single agent PD-1. We've got data on PD-1 combined with CTLA-4 with nivo-ipi. We've also got balstilimab, anti-PD-1, zalifrelimab, anti-CTLA-4. AK104 is a bispecific PD-L1 CTLA-4. Ventroprus alpha is a PD-L1 inhibitor with the TGF-beta, moiety bispecific. And then we have a TIGIT, tiragolumab with atezolizumab and under investigation in a trial called Skyscraper. And then again, soquelizumab, which was presented at IGCS, which is under investigation in China. This is not currently available in the United States. So this is what's going on. This is last year, Dr. O'Malley presented these data at ESMO, the preliminary data on the BAL and the BAL-ZAL combination, 2 independent trials looking at these, and showed responses that were comparable to Pembro in the PD-L1 positive, but also showing responses in the PD-L1 negative population with the PD-1 inhibitor alone, and then increasing that response rate with the combination of the CTLA-4 without much excess toxicity. And there's going to be another update on this at ESMO upcoming. So looking forward to that. So for those data, BAL-ZAL got a fast track designation. And in the GOG, hopefully you're either participating or know someone who has this trial open. This is RAPIDS, which is a randomized but non-comparative trial looking at the single agent versus the combination. And there's a placebo given in the BAL only arm for zalifrelimab, and that's to sort out the relative toxicity of the combination. It's not to compare the efficacy. So this trial is still a high priority, and we'd like to get this done because, as you can see, the field's moving very quickly and we need to keep moving forward. So Brad gave me this slide in February, and as of April, a lot had changed. We had the results of Empower. TV had already put in their BLA and received the PDUFA date, as you heard earlier from Brad. And as of September, now we have Keynote 826 coming online. So this is like, I mean, you guys know, you've done cervical cancer forever. You know that this kind of progress has never happened in cervical cancer. And so I'm just really grateful that people are interested and we're making progress. I'm gonna hand this back over to Brad. Thanks.
Leslie, that was amazing. And Brian, thank you again. Lifileucel.
Lifileucel.
I've been practicing.
I'm always the last to know how to pronounce it.
So much fun.
So
so we have some key dates coming up. You talked about them. So 826, 240 plus Pembro will be presented next Saturday on the 18th. And then October 10 is what you said, Brian, the PDUFA date for tisotumab vedotin. It could be earlier or later, and it may not get approved at all. And then balstilimab is December 16th. So September 18, October 10, December 16. You have 3 key milestones. And this idea, Leslie, that in 1999 you weren't born yet, you know, GOG 109 was my first JCO paper. So you were not even born in 1999, and I was excited to have a JCO publication. But way to go.
Depends on your definition of born, but yeah. Okay.
So we have plenty of time, and thank you for being mindful of that. I want to talk about antibody drug conjugates. I think that this is the next mechanism of action. I think you've seen that we have, you know, PARP, VEGF, and IO, and now we're going to have ADCs. These are my disclosures. Thank you. But antibody drug conjugates, which we call ADCs, there are really five components, because I don't have the target in the FC region. The FC region may or may not be important, but these three critical components are the antibody and the payload, obviously the cytotoxic. It's highly potent, more toxic than the traditional cytotoxic agent. And then the linker, because it has to disassociate from the antibody. And I'm not going to get too much into the mechanism of action. We have multiple folate receptor antibody drug conjugates in ovarian cancer. We have mesothelin in ovarian cancer. We have NaPi2b in ovarian cancer. So ovarian cancer is hot on the heels of what we're doing in cervical cancer. And really, we're just trying to catch up. So these are the antibody drug conjugates currently approved for cancer therapy in the US. And you can see it started in AML, TDM1, trastuzumab emtansine, improved in 2013. And then ultimately other solid tumors, metastatic urothelial cancer, gastric, and ultimately triple negative breast. So, I like what we've done with PARP inhibitors, ovarian cancer. We were first. We're not the first ADC to come online, but I think tisotumab vedotin will be the first one, at least for GYN. So antibody drug conjugates are here to stay, and we really need to sort of become familiar with them. And I think that's sort of the key deliverable here today. So tissue factor is the target. It's a transmembrane receptor, a part of the coagulation cascade. And it has some roles in the extrinsic pathway for coagulation. And in cancer development it drives angiogenesis. And my passion and your passion for anti-angiogenics. And it also drives proliferation metastases. And because it's part of the clotting cascade, it also drives thrombosis. And it's basically overexpressed in all cervical cancers, which is very unique. So many of the antibody drug conjugates, such as folate receptor, as you know, or NaPi2b or mesothelin, you have to sort of measure it. We don't have to measure the target because it's so highly expressed. And that is an efficiency here. And I'll talk about that a little more. So basically, it is directed to this tissue factor, and it is covalently bound to this MMAE, this protease cleavable linker, which I talked about the linker. It binds to thromboplastin, which is tissue factor, and then ultimately is endocytosed and has some direct cytotoxicity. And then ultimately, maybe because of its immunogenic cell death, has an immunologic opportunity, and then has an antibody bystander effect, a cytotoxic bystander effect. And so it not only may it have immunogenic cell death, but it also might have an antibody-directed cellular phagocytosis. So it's a very interesting molecule. It's made by Seagen. And Seagen probably is the world leader. Many of those antibody drug conjugates that I showed you are Seagen products. There was a phase 1 study. I think, Brian, you were a part of this. And in all tumor types, you treated, Brian and others, 55 patients, and there was a signal in cervical cancer, a signal of 24% response rate. And when they looked at it with the independent review committee, the blinded independent central radiology review, it was confirmed. And you can see that there are many patients that had significant tumor shrinkage. So under the GOG sponsored an advisory board at ASCO almost 3 years ago. And we sat down and we said, look, we can probably do a single arm phase 2 and get accelerated approval. And that study grew out of here. We decided to collaborate, as we always, generally, not always, but try to do, with NGOT. GOG was the lead group. The lead group leads to the first author. NGOT is a participating, so the last author is an NGOT member. And the company was Genmab at the time. So the development in cervical cancer is Genmab, but the sales and marketing is Seagen. They call it 204. I call it 204. You can call it by its GOG or NGOT number 3023 or CX6. And so it was a single arm trial with the intention of getting accelerated approval. And we did it. The PI, the GOG PI was Rob Coleman. The dose was 2 milligrams per kilogram based on the earlier phase 1 every 3 weeks. So it's an every 3-week medication. Again, it's weight based, and it was given until progression or unacceptable toxicity. And in order to get accelerated approval, you have to sort of go to the independent radiology committee because there needs to be confidence. It's not some investigator assessed response, although I think we're all very trustworthy, but they want really verifiable results. And they did that. And I'm sure you've seen that, but it was exciting. 24% response rate. And the first time we saw that, the first thing Rob said, wow, Pembro is 14. So, and it's true. And Brian showed that very nicely. I don't know if the tumor shrinkage sort of kinetics is any faster, but there's no question that this is more, it's not a comparison, so I can't say there's no question. There's a suggestion that this is a more active agent than single agent checkpoint suggestion. And the duration of response was long, over 8 months. So people always say, well, Brad, Pembro is a good medication. The response rate's only 14.3%, but the duration is long, and that's true, okay? It's also true here. And you've seen that there are some negative approvals, let's say retifanlimab, which is a checkpoint inhibitor in HPV anal cancer, had an ODAC, and they got rejected, which is called a complete response, because although they were responders, they weren't durable. So you got to actually be right 3 times. You have to have an acceptable response rate, they have to be durable, and then you have to have a safety profile that's acceptable. And I think that this is that. And there were even some complete responders, which was very encouraging. So this is very interesting, and I want to sort of review it in detail because this is the way we treat patients, right? So we'll see a patient, well, let's see the histology. Well, the first shows that the response rate in non-squamous and squamous tumors, 25 versus 23%, about the same. So you mentioned, Leslie, about the PD-L1 status. So in cervical cancer, PD-L1 status is about 80 to 90%. Those that are negative are almost always adenos, and those that are PD-L1 negative, 10 to 20%. Some of those are MSI high, and some of them are mutational burden high. But many patients, there's a difference between adenos and squamous, and the HPV types are different. Adenos have more 18s, and the bevacizumab response might be different. But here it appears to be the same. It's also the same for prior chemotherapy and radiation. It's not the same with prior lines of therapy. You can see if it's sort of a second line, that is one prior line is 28%, and I'm looking right here. But 2 lines is 13. So I think, like most medications, the sooner we use it, the better. And patients that are responding probably do a little better. Again, this is all inferential, 26 versus 21%. The interesting thing is here that, and it's inferential, I mean, it's hypothesis generating, not testing, that the bevacizumab naive patients did a little better, 32 versus 19. And obviously the more fit patients, ECOG 0 had 31%. I'm a little competitive. The US patients did better than the EU patients. And as I mentioned, our site here in Phoenix was the top enroller in this study. So we have experience with it. We're excited about it. And this is sort of the information, if it does get FDA approved, that will be in the label and already in the paper. It was published in Lancet Oncology earlier this year. So this is the progression-free survival. Patients are not on it a long time, but they do seem to have, again, inferring maybe a little bit of an overall survival benefit. So 24% response rate, 8-month duration of response, okay? The average PFS is about 4.2, but the DOR is 8. Now, these are the adverse reactions, and that is the third, part of the stool, right? And you can see that the font isn't that great, but it basically is the cytotoxin, the tubulin agent that causes the adverse reaction. So you have some marrow suppression, some anemia, some neutropenia, And the antibody drug conjugate can disassociate in the eye. So you have some eye toxicity, and you also have some bleeding. And I'll show you on the next slide. But that you sort of have to understand that this is basically a microtubule active medication with some potential for some eye adverse reactions. And you really have to sort of understand that. So who is the wrong patient for this? The patient with pre-existing neuropathy, grade 2 or worse. But who is the right patient? Well, a patient that wants to fight her cervical cancer. Not every patient does, but if she wants to fight it, other than chemotherapy and Bev and Pembro, this is it. And you guys said that in a poll. And so our mission within the GOG and as an investigator is to bring this to the clinic. And you can see here the ocular bleeding peripheral neuropathy. So those are the sort of special interest adverse reactions. And again, these slides will be available to you. The video will be enduring up for 6 months on the GOG website. Now, the ocular are very interesting because, as you can see, they resolve. 86% of them resolve. So don't anyone say that this is really seriously affecting the eyes, but it's a conjunctivitis. So I have a red eye. This looks like pink eye. And so we need to manage that. The bleeding is predominantly epistaxis. It gets better, 90%. And ocular takes a couple cycles. So the number of cycles to get ocular adverse reactions is about 1.5. Bleeding happens right after you start it, and I'll explain why. And neuropathy is cumulative, so it's 3.1 months. And again, it's a 3-week cycle, 2 milligrams per kilogram. And they resolve quickly, right? So you see the median time to resolution is a couple weeks, okay? So I need confidence for us as we roll this medication out that it's the neuropathy because it's an antitubulin, the bleeding, which is generally epistaxis, and the ocular, which is sort of a conjunctivitis, and we can help you with that. The ocular is interesting. I need you to sort of understand the 3 pillars of adverse reaction mitigation. So the first is eye drops. And so we give a vasoconstricting eye drop before the medication is given. So if there's some vasoconstriction in the anterior chamber of the eye and the surface of the eye, then the drug delivery is lower. Makes total sense. And then steroids, if you do anti-inflammatory, and the steroids are actually continued for 3 days, okay? And you can also get a dry eye. So the lubricating eye drops are for while the treatment is going. So you have 3 eye drops, the vasoconstricting eye drop before you treat it, okay? And then number 2, the steroid drops, okay? And then ultimately the lubricating drops, okay? And then the next thing is that you use a cold pack because, again, the ice, low thermal cooling causes vasoconstriction. And we've learned that if you cover the eyes, and remember, epistaxis is there, so we can actually cover the nose. And so there's vasoconstriction, not too cold, so it burns. It actually kind of feels, my patients say, kind of feels good, particularly in Arizona where it's so hot. So you put those cold packs on the eyes and on the external nares, okay? And then ultimately, the third mitigation strategy is that these patients need to have access to ophthalmology. And so generally we have them check in with the ophthalmologist before they begin treatment. So it's eye drops, cooling, and eye care specialists. And again, the timing is predictable. Ocular is, after about 2 cycles. Bleeding is generally early on because you didn't do the cold pack. And the peripheral neuropathy is cumulative. They're almost all reversible except for the neuropathy. The neuropathy doesn't really get better, just like any other antitubulin medication. And it resolves soon because you can also dose reduce. And there's a dose reduction schedule, just like every other cytotoxic. And again, the contraindication is patients that have neurotoxicity. So it's been filed. And it was filed on April 21, and I told you it's going to take, let's be quick, 6 months because there's I guess 8 months. 4 awarded. It's 6 months, but that's when it was announced. It was filed 2 months earlier. So it was announced on April 21st, but it was filed on February 21st. Okay. Why? Because if the application would not have been accepted, you never would have heard about it. So the announcement came and it basically said in April that yes, we filed it, and the FDA said we'll accept it. And there are rumors out there, for example, that bevacizumab GOG 218 got sort of traffic to the FDA 2011, and it did not get it. You never heard about it, but ultimately it did. And frontline bevacizumab in ovarian cancer got approved in 2018. So this prescriber user drug fee act has a target date of October 10. It's a new entity. That's why it's 8 months, not 6. And we'll see. And I hope that this has been informative. I'm going to stop here. And if I could ask Leslie and Brian to turn on your cameras, and we have 15 minutes right on time for questions. So I'm going to maybe just while these questions are coming in, put you guys on the spot. I like to do that. It's the fun of it. So Brian, you're the endometrial lead, and we have dostarlimab now. In fact, dostarlimab got a MSI high all tumor type approval. You probably heard that. But we have dostarlimab in MSI endometrial cancer, and we have pembrolizumab. So you know where I'm going. Is there any reason to have dostarlimab, or is it just a pembrolizumab world? And then while you're thinking of your answer, I'm going to ask you the same thing, Leslie. Is that soon we're going to have sort of the same scenario: pembrolizumab, cemiplimab, and balstilimab? And does it really matter? And do we need that, or is just one agent sufficient? So Brian, give us the endometrial. I realize we're talking about cervix, but it's important because there are some choices here. Which checkpoint inhibitor? Go ahead, Brian.
Thanks for that, Brad. I do think that it's important to have a couple of drugs, even if it's the same mechanism of action. There's always some subtleties and differences between, one of the key example there is what we've learned from PARP inhibitors in ovarian cancer.
Yeah,
which
right.
is outside the scope of this talk, but there are some differences. The important thing is to look at the data, is to evaluate the differences and to treat as appropriate. For example, the Empower data did have was not biomarker driven, and it also looked at adenocarcinoma patients, and there was an advantage there, while pembrolizumab didn't really focus on that. So oftentimes there's some subtle differences between the drugs in a class. Even without that, in the world that we live, there's different agreements or reimbursements for different drugs by different insurance companies. So I'm all in favor of a competitive market, and I think that it's nice that we have more than one drug available for this disease. And moving forward, there is given the widespread use, there is definitely a role for multiple drugs.
Is that relevant, Leslie, in cervical cancer with 3 checkpoints? Did Brian steal your answer?
No.
You hit the mute button by accident.
Oh, I'm always muted. That's just my brand. Yeah, I often agree with Brian, and I do, and he didn't exactly steal my answer, but what better disease for there to be a competitive market than cervical cancer?
Mm-hmm.
I mean, really. And honestly, you can look across, and people do this, and I did this in my slides. You can look across the response rates for the single agents in the small, in the small phase 2 studies, which we've had completed, and you can try and cross-trial compare them. The bottom line is that all the confidence intervals overlap. So really, they're probably the same. And I agree with Brian, there may be some subtle differences. And if you haven't read, if you haven't seen our publication on balstilimab and G1 oncology in the last month, I encourage the audience to go look at that and look at the efficacy that was shown in that study. And there may be some subtle differences, especially in the PD-L1 negative population. But I love the possibility for there to be some cost containment and market competition.
So you know what I do, Brian? I say, hey, my patient's MSI high endometrial cancer, and someday I'm going to do this in second line cervical cancer and checkpoint naive. And I'm going to tell my nurse practitioner, Kimberly Hall, if you may know, give her the one with the lowest copay. Mm-hmm. Done. And I would hope that there might be one of those companies, particularly in cervical cancer, that says, we're not going to have any copay. maybe I'm out of my mind, and maybe I am, but that's interesting. And so I want to introduce a question, then Brian, I'm going to ask you another question. So I took these slides out, but I presented at IGCS what this gentleman just said. He said, "Hey, Brad, why can't you combine TV with Bev?" And I would expand that. Why can't you combine TV with Carbo, or even, TV with Pembro? So you got these three agents: chemotherapy, Pembro, and Bev. Why can't you just combine TV? And you did, and we did. So, and I didn't go through the data because the answer is simple, is that there's no overlapping toxicities. You can use a carboplatin dose of 5, AUC of 5. Okay, you can use the standard bevacizumab of 15 milligrams per kilo every 3 weeks. And there's no bleeding risk, which was interesting. We were concerned about it. And you can go ahead and do the Pembro 200 every 3 weeks. So you can, and you'll hear, and I didn't do it because at ESMO next week, week and a half, there'll be the expansions, and you'll see that there's some efficiency. You'll see that actually TV and Carbo is kind of synergistic. But TV Bev and TV Pembro are additive. It's kind of cool. And it may be, to your point, that I asked that question. So in second line, you're going to use TV or chemo. Someone may say, if the patient's checkpoint naive, I'm going to try to get TV Pembro paid for. I'm going to do both at the same time. So I did not talk about, Brian, your GOG trial 301, the confirmatory trial, which we're trying hard. So I'm going to give you a chance to introduce the randomized phase 3 trial that would be the confirmatory trial for tisotumab vedotin, and maybe you can provide some color to that. You're muted too.
I'm following Leslie's lead. So yeah, no, we are, a lot of times when we are looking for rapid approval, the FDA does require a confirmatory trial, and that's exactly what we're doing. It's a randomized phase 3 trial that we're partnering with our colleagues in Europe, which we're, as a side note, we're doing a lot of trials that are now international as opposed to just national. It's great to work with them. And what it is comparing TV versus sort of clinician choice chemotherapy in the second line setting to see if in fact we could confirm the findings that Rob showed and some of these other trials of TV's activity in cervix cancer. I'm really excited about it as the national PI of it. We're really encouraging our sites to take part. As of today, it's the only way to get TV potentially for our patients in a randomized trial. While that may change based on the date that you talked about, based on the FDA approval, we will still rely on international approval in the confirmatory setting. So if you're a GOG investigator that has this trial open, call or text me anytime to see if there's anything I could do to help with your accrual. Related to the ocular mitigation plan, it's working. We didn't know about it in the earlier trials, or we didn't know how to do it precisely in the earlier trials. We're doing it now, and the ocular issues aren't as vital. So go out there and accrue your patients, because we always encourage accrual, and any questions, give me a call.
Right. So I have a point from the chat. Someone said, the other difference between TV and Pembro is that you got to get the PD-L1 testing. So it creates a workflow challenge. So not only is the response rate, again, there's no comparison, but inferentially compared TV versus Pembro, you don't have to wait for the biomarker. And
I really want to emphasize, patients are allowed prior checkpoint in order to go on TV.
Yes.
Yeah.
Thank you.
That's not the case for some other promising drugs. Some of you have the Iovance drug, which is a great drug, or a good drug, I should say. The problem there is, while a lot of patients are getting checkpoints prior, there is no data, despite our encouraging the clinical trials to look at it. There's no data on treatment of the TIL therapy after checkpoint. So, even though a lot of these patients are going to get checkpoint, which ultimately is okay, we're really looking for a second or third line indication, which will allow for prior checkpoint.
Yeah, I do agree with the biomarker, but in the spirit of being fair and balanced, and there's a question in the chat that asked, is PD-L1 even relevant after, Empower, and now with Keynote 826 showing responses, regardless of PD-L1 status? We don't know is the answer to that question. It'll be really interesting to see what the FDA does with that. because we do know that they're very keen on the biomarker currently, but we don't know what they'll do with these new data. So stay tuned. We can have another webinar when we get these approvals and we can talk about it.
And it'll be interesting really to see, because you have the PD-L1 status, which I sort of out of the blue said it's 80 to 90%. And those that are not PD-L1 positive or adenos, and some of those are MSI high and TMB.
Mhm.
So we may be talking about a pretty insignificant subset. We'll have to really see what the demographics are. And then Brian, to your point, your randomized phase 3 trial that we're doing is really important for Europe, because accelerated approval, we're jazzed up and we're here, you know, but it's only in the US and a few countries. You know, when we got pembrolizumab approved in Europe, it utilized an efficiency mechanism called Project Orbis, and we got it in Australia and Canada and ultimately Singapore and Switzerland. But the majority of the world didn't have access to pembrolizumab in endometrial cancer until, you know, you guys did Keynote 775. So Leslie, you said some things beyond ADCs, and you know, you said checkpoints are moving earlier. You also mentioned lifileucel. What's next? And maybe we don't know. Maybe we're reaching a plateau. What's next? Or you also discussed some other things. Kind of what are you excited about as the next opportunity?
Yeah, I mean, I feel like we can't be reaching a plateau, right? Because if you look at the PFS curves in Empower, it's exciting that there's an advantage over physician's choice chemotherapy, but look how low that bar is, right? And so just because we cleared the bar, it doesn't mean that we got the gold medal. I think that, you know, combinations, like I presented combinations of checkpoint with, I mean, checkpoint does work. So I think checkpoint combinations will be important. I think there is a role for TILs. We just have to, you know, deliberately figure out what that is. And then combinate, like you just presented, the TV combinations. And then I think, you know, we have subsets of cervical cancer that are targetable with other targeted therapies, are just really difficult to study because they're so rare. Our HER2 positives, our PIK3CA mutated, so we've got, you know, from the TCGA, some indication that there are some molecular subtypes that may have targeted therapies that benefit. And, you know, these trials don't even address neuroendocrine.
Right.
This is all squamous, adenosquamous. So, you know, some of those rarer types, we haven't even touched that yet.
You know, I have the privilege of talking to you all the time. So I'm going to tell you something that you told me, and you're such a great communicator. You basically said, look, Brad, we can make single agent PD-1 better by adding it to chemotherapy and radiation. We're studying that. You know, we can make it better by VEGF, you know, lenvatinib in endometrial cancer or Keynote 826. But probably another option that we really need to focus on is plus CTLA-4. And then what you always say is, why do we even bother with chemotherapy? Because some of these novel combinations are so good. See, you're laughing because that's what you always
I'm laughing because I'm obsessed with replacing chemotherapy with immunotherapy.
I know you are. I know you are. All right. So Brian, I'm going to give you sort of a closing remark, and then Leslie a closing remark, and then we're going to wrap it up. Thanks. So go ahead, Brian. Any summary statements?
General comment. It's such an exciting time moving forward with immunotherapy and cervical cancer. We keep learning more and more. We're pushing it into the frontline setting. It's here to stay. It's best for our patients. It's going to help our patients live longer. And that's what it's ultimately all about: FDA approvals and improved survival. So I'm excited to be a part of this era. Thank you.
Thank you. Closing comments, Leslie.
I totally agree. And I'll add that, you know, this is a population that's plagued by disparities and disenfranchised patients with, you know, we got to address that elephant in the room. It doesn't matter if we make progress if it's not available to people that need it.
It's true. And so that's obviously all of our passion, that if it's not in the clinic, we really haven't done anything. And then is what we're doing here. Even if it's in the clinic, if we're not using it in a responsible way, we still haven't really been, you know, successful. So I'm excited. I can't imagine. I never would have dreamed that all these agents and combinations would have been in development. I want to thank both of you for being with us. I want to thank the GOG Foundation, Jenna Cummins, Lindsay Moeller, Linda Gildersleeve, and obviously President Copeland for being with us. And thank you, and hope to see you guys again soon. And maybe we can celebrate a TV indication sometime soon. So thank you. So long for now.